Hello, everyone. Welcome to another Monday of VMRs, specialty in clinical reasoning. Today we have very special guests with us, and I'm very happy to tell you that this is my first time facilitating, so bear with me a little bit. And well, to start today, we have three guests. Our first guest is Ashvin Kaur. She's a molecular geneticist and final year medical student hailing from Brunei, currently studying at Taylor's, Malaysia, with a keen interest in oncology, acute medical care, and accidents and emergency. Wow. Ash is passionate about the field of medicine and is always eager to learn more. When not studying, Ash is a true foodie, avid dog lover, and somewhat decent gamer. Welcome, Ash, and tell us more about your interest in medicine and also outside of it.
Hi, everyone. So my name is Ash, as you guys have heard. I am quite interested in medicine, actually. It has been a growing passion since I was young. So initially I did molecular genetics, but then I realized that I'm more of a people person. I wanted to be in the, sort of in the front line, helping people and communicating with people. So that's why I'm like, no, I do really want to do medicine after this. So I took it upon myself to do it. And I don't think I regret the decision. It's quite an enjoyable career path.
That is impressive, geneticist, and also accident and emergency. I think I was telling her earlier that, wow, I don't know if I could react so fast. That's really impressive. Our next guest, Shanisa, a final year medical student from Taylor's University, Malaysia. When it comes to medicine, Shanisa has a soft spot for the pediatrics field and is hoping to embark on that journey in the near future. Outside of medicine, you will find her spending time with her loved ones, family, and friends, either traveling to new places, trying out new baking recipes, or having movie nights. Hello, Shanisa. Why don't you tell us about more pediatrics? Why do you like pediatrics?
Hi, good morning, evening to everyone around. So pediatrics has always been an interest of mine because even as growing up, I've always loved hanging out more with the children at parties. That's where you'll find me. So along the way, I realized I do have a soft spot, and I'm really hoping that in the near future, I would be able to embark on that journey. And other than that, you'd find me, I love trying out new things. I've got a little bit of an adventurous side outside of medicine. I love traveling to new places, and hopefully soon I'll be able to travel to where everyone is and meet some of you. So that's just a little bit about me.
That's super cool. Honestly, I think we have some interests, people here in pediatrics. And of course, we have a very variety of countries here present. You can see Brazil, Germany, everywhere. And our going into our last but not least, our case discussion, Dr. Lavanya Narayanan. Dr. Lavanya is a board-certified internal medicine specialist with an interest in diabetes care, a medical educator, and the founder of Medit, a medical education creative studio based in Kuala Lumpur, Malaysia. With a passion of advancing medical education and fostering career growth for doctors, she established Medit in 2016 to offer comprehensive postgraduate training programs, including the Royal College diplomas in the UK, such as MRCP, MRC Psych, MRCS, and more. Under Dr. Lavanya's leadership, Medit has successfully assisted over 4,000 doctors in their professional development, utilizing innovative digital learning platforms like CME Academy to deliver high-quality educational content. Welcome, Dr. Lavanya. Why don't you talk about Medit? This is amazing.
Oh, thank you so much. Thanks for the introduction. Hi, everyone. First of all, I must say that it's a dream come true to be here. I've been following CP Solvers for some time now, and I think just like many of you guys out there, it is so surreal to be here and finally meet you guys. I've been talking about this for more than, I don't know, half a year now since I got the message from Maddie. So I'm extremely glad and honored to be here today. Thank you so much. A little bit about Medit. So it's actually a
a very small a small company we started back in 2016. I was doing my first year medical officer term in Malaysia. That's right after internship. And at that point of time, I completed the Royal College papers as I took them early. And from sharing notes with my friends and colleagues around, today it has turned into a company with programs and workshops helping our local and also foreign doctors to clear their Royal College papers before they could, qualify to become specialists in our country. So that's a little bit about it. And Shanisha and Ash has been with me for a couple of years now. They are one of the contributors for Medit. They are doing an amazing, awesome job. I'm so thrilled to have them with me here today. But unlike their passion, I will stay far away from pediatrics and accident and emergency. As much as I love kids, I don't think I want to see sick kids around me much. So yeah, internal medicine has been my passion, and I like the entire clinical reasoning process. And I hope that becomes a very big major area in our medical education arena one fine day. So I think you guys are paving the path for it, and thank you for that. Thanks for having me.
No, thanks you for joining us and to teach us from Malaysia. We have a very multicultural group here, and we are all in for medical education. So why don't we start with the case? I believe the scribe, who is the scribe today? Who can share the screen? Thank you, Shema. Whenever you want to start.
Okay, so hello everyone. So let's get started. So a little bit on our patient. So we have a 35-year-old male who's referred to the hospital for acute shortness of breath with accompanying bilateral upper and lower limb swelling for duration of 1 day.
Okay. You want to stop there? You're done with the chief complaint? Okay, thank you very much. So here we have a 35-year-old male that comes in very interestingly with a 1 day history of shortness of breath and bilateral upper and lower limb swelling. So I'm just a little curious to understand, was there any timeline difference in terms of the breathlessness and the swelling? Did it happen all together? Because I'm trying to see if there's a connection. Or was there a progression of symptoms that took place? So it started off with either the breathlessness first, followed by the swelling, which became more apparent, or the other way around, or did it happen all together? Because that will give me a broader understanding to are these two group of symptoms related, or are they separate situations altogether? Yeah. Do you have that information for that?
Yes, so the symptoms happen concurrently, both over the duration of 1 day.
Oh, okay, interesting. So for a young person, assuming that he had no previous medical illnesses before, coming in with acute breathlessness and anasaka, if I may say, upper limb and lower limb swelling, of course, having a little bit more information in terms of the facial puffiness and so on, I'll be definitely thinking in the line of something very acute, dynamic, something systemic, because it's involving both upper and lower limbs, the entire body, as well as the pulmonary component, perhaps the cardiac component as well. So a systemic problem will be something that triggers my mind. And I would also like to know if the patient had, of course, any important associated symptoms, which I believe you all will be sharing with me later in the history of presenting illness. So whether the person had a previous existing medical condition would be a very important point for me at this juncture, because I would like to know whether it's a recurrence of an existing problem, or is it a progression of an existing problem or worsening situation, as opposed to something extremely new that's taking place at this point. And if it's extremely new, then there are many questions that's running through my head, because it's quite rare to see someone come in so bloated over 24 hours. So was there something that was subacutely going on in the background that we did not catch on. And this is the outcome that we see after a day. So of course, thinking in the line of vascular, thinking in the line of, the cardiac component, these will be important situations. Apart from that, another important thing that we cannot miss out in a person who comes in with edema would be allergy or anaphylaxis, to be specific. So something so acute as such, and if you're going to tell me a little bit more about this patient later, whether, if the patient had previous problems before. If not, then I'm definitely considering anaphylaxis. So angioedema, leading to difficulty breathing, as well as the generalized swelling that you're seeing both upper and lower limbs. This would be among the conditions I would consider. So like I said, systemic, it has to be involving more than one systems. I want to see whether it's related or not related, but if they are both happening at the same time, then most certainly I'm thinking it's got to do with one another. Yeah.
Wow, and this is an amazing approach for an acute versus chronic evolution of edema. Thank you for that. Shaneza, would you like to give us more information?
Yeah, sure. Okay, so moving on to the history of presenting illness. So prior to his current episode of shortness of breath and bilateral limb swelling, he actually had an episode of fever, which started about a week prior. So it was low grade in nature with some accompanying nasal congestion. There were no other remarkable symptoms, and he claimed that it resolved by day 3 of the illness. And following which, on day 4, he developed episodes of vomiting, about 3 to 4 episodes over the span of 3 days. As for the content of vomiters, it was as per oral intake with specks of blood. And concurrently, there was also associated blackish stools, also 3 to 4 episodes. However, the patient denied any fresh rectal bleeding. So the episodes of blackish stools and vomiting, both according to the patient, resolved by day 6 of illness. So would you like me to move on, or shall we?
Okay, I think I can elaborate a little bit from here. So as predicted, there was a preceding sort of prodrome that came first. So here we have someone who had fever 1 week prior that lasted for 3 days. It was low grade with some nasal congestion, giving us, perhaps it's a common flu or a viral infection. However, day 4, very interestingly, the patient started developing, he started vomiting and blackish stool. Yeah, so blackish stool is very subjective. We've got to be a little bit more, how would I say, specific in the sense that was it, I would like to know if it was melena, because whenever we say blackish stool, we want to, exclude upper GI bleed. But here, having said, this is probably something different. He had never experienced this before. So that's why that's a particular complaint that he's mentioning 3 to 4 times a day, which is still abnormal because, increased frequency of passing stools in a day. So that perhaps also had some GI implications going on. Whether it's related with the fever, could this be an acute gastroenteritis per se? But it's a bit unusual to have nasal congestion, involvement of the respiratory tract as well. So we can see here there were more than one system involvement that preceded the acute presentation of dyspnea. I'm still thinking in the line of anaphylaxis developing, but then it is a bit abnormal for it to take place over a period of 1 week. Yeah, 24 hours seems like a better time, a more reasonable timeline. And the bleeding, you mentioned no fresh rectal bleeding, and day 6 resolving of bleeding. So was there bleeding anywhere else that resolved?
There was no other bleeding other than it was actually melena and vomiting.
All right.
So yeah, it both resolved by day 6.
Right. Right. So for someone to develop melena, I would definitely want to know the past medical history, because you're thinking approach to upper GI bleed. I would approach it in a way that, is this a variceal bleed or is this a non-variceal bleed? This is after I've confirmed it is a melena. And in that sense, I would need to get a little bit more information as to if the patient had any form of peptic ulcer disease, if the patient had any clues to chronic liver disease with cirrhosis. And usually variceal bleed, they vomit, they have hematemesis. For melena to develop, it must have settled in the upper GI tract for some time, definitely more than 24 to 48 hours for it to develop and be shown in their diapers or on the bed. So but there are few situations that's going on. I can't seem to tie them up yet, but I believe there probably is more than one problem here. It is not only the dyspnea and the swelling. They have also, shown me that there's involvement of the GI tract. I think you can carry on and give me a little bit more clue to see what's going on.
Okay, sure. So upon resolution of the above mentioned symptoms, the patient developed a one-day history of shortness of breath. It was sudden in nature and it was mild. There was no associated noisy breathing. However, the patient did mention that he was fatigued. Hence, there was some reduction of his daily activity. And concurrently, he also developed the bilateral upper and lower limb swelling, which was also sudden in onset. And there was no associated pain or redness noted with the swelling. Adding on, he also stated that there was a generalized abdominal discomfort and claimed to note that his abdomen was grossly distended, per se.
Mm-hmm. Okay, interesting. So I presumed earlier on when you mentioned bilateral upper and lower limb swelling, I was thinking in the line of Anasaka, and the other one was anaphylaxis. So if it's Anasaka, I also would have considered the patient coming in with ascites. Yeah. And earlier on, just backtracking a little bit, the approach to edema, whether is it decreased plasma oncotic pressure due to very low protein levels, or whether is it increased capillary hydrostatic pressure, or is there increased permeability or capillary leakage? That could be secondary to angioedema. It could be due to any other insults to the capillary wall. So at the moment right now, given the history of low-grade fever with blackish stool and then the bleeding resolved, so there was evidence of melena. Of course, understanding if the patient was exposed to anything before, meaning to say, was there any particular drugs or medications that could trigger bleeding tendencies in the patient? That is also something that I want to think about. For example, the use of non-steroidal anti-inflammatory drugs stand a chance to precipitate an upper GI discomfort or a peptic ulcer disease, and can present with melena in a very sick person. Also can trigger an allergic reaction because not everyone do well with NSAIDs. So perhaps understanding the chronology of how the first week of fever was dealt with. Did he seek any medical treatment? Did he go to the pharmacist and buy any over-the-counter medications? Is he taking any herbal remedies or treatment? These will be among the things that I would like to ask, apart from understanding if the patient had any existing past medical history to help me out a little bit. May I also just find out about the weight? So did the patient experience any weight loss in the last couple of weeks or months, or was this the only isolated episode the person had and he was previously completely well?
Yes, the patient did not have any prior loss of weight.
All right. Okay. Do you have any more information for the history of presenting illness so far?
Yes. So far, just that's pretty much it for the HOPI, but a little bit on the review of systems. Just to let you know, there was no remarkable renal system symptoms or cardiovascular symptoms such as chest pain noted in this patient. There were no bleeding tendencies other than the one that was above mentioned. There were no upper respiratory tract symptoms. And also, however, the only significant constitutional symptom that was noted was the loss of appetite that the patient experienced over the past couple of days. That's pretty much it.
It was interesting you mentioned absence of upper respiratory tract symptoms. So in someone who comes in with acute breathlessness and swelling, generalized edema, considering anaphylaxis as one of it, so they can, another important area to focus on is whether do they have any form of upper airway obstruction. Okay, and that will manifest as noisy breathing or stridor, or they might have some changes in their voice because of laryngeal edema. So these are very subtle things that start off first before it kind of, blows up into full-blown acute respiratory distress or obstruction of the upper airways. Now, I believe at this point of time, the patient didn't have all these symptoms. So moving a little bit away from anaphylaxis. And also, I didn't get any information about that any changes in the skin appearance, because that's also something that will be present in someone with an allergy or anaphylaxis. There's dermatological involvement apart from the pulmonary, cardiac, GI system that can get affected. So I presume there was no skin involvement at this point of time. So basically now, just to very quickly summarize the chief complaint and HOPI, I have a very young gentleman, a 35-year-old previously well person who had come in with an acute episode of dyspnea and edema, generalized edema. This was preceded by a 1-week history of a 3-day history of fever, which happened 1 week ago, and it resolved by itself, then followed by vomiting and passing melanic stools. He also had just generalized fatigue. I think that would be easily explained by the fact that he was passing multiple episodes of stools. He was having diarrhea, melena, he was losing blood, and also he could be fatigued because of the breathlessness. So moving on, if there's no other systems that's involved, I'm still thinking that these two problems could be isolated. And I can't seem to really see a connection at the moment to come up with a diagnosis yet. But perhaps some past history might give me some clue.
Of course. Thank you for this, Dr. Lavanya. So far, what should we consider in our differential aside from anaphylaxis with this information when we see a patient like this?
All right. So first of all, if I'm seeing this patient now, importantly, I want to ensure if I'm dealing with an increased capillary hydrostatic pressure state, which is heart failure, okay, or if there is a concomitant renal problem as well, because the patient is appearing to be very edematous. So there might be a component where there is reduced renal function, or if the patient is having nephrotic syndrome. So I'd be expecting to get a history of frothy urine, even though that's not something that they very commonly bring about or able to comment on. Other than that, yeah, I'm still banking on anaphylaxis because it's just extremely acute. I mean, for fluid to build up over 24 hours, it's extremely rare to see that happening. Unless unless it has been happening subtly and he noticed it in the last 24 hours, especially with the breathlessness. So I'm thinking, is this pulmonary edema? Is this pleural effusion? Could this be unlikely to be pneumothorax, even though it is within the duration of 1 day, but an X-ray will give me an idea very quickly. And given the fact that the patient has got no previous risk factors, still be a consideration, but I can't seem to see the correlation of it with the bilateral upper and lower limb swelling. these will be my differentials for now. Apart from that, also considering very low states of albumin can lead to hypoalbuminemia, leading to edema. So these are the considerations I'm having at this point of time.
Okay, thank you so much. So we should be wary of cardiac, lung, and kidney issues so far.
Mm-hmm.
For the next aliquote, past medical history.
Okay, so yes, for the patient's past medical history, this is his first hospital admission. He has had no prior surgeries that have been done before. He has got no known underlying chronic medical illnesses such as diabetes, hypertension, cardiovascular disease, or hypercholesterolemia. However, the patient claims to have gastritis, but he's never done a scope prior to this. So that's a little bit of the patient's past medical history.
And was there any particular medications or treatment he was taking for the gastritis?
Yeah, according to the patient, he was not on any medication. He was not on any over-the-counter medication as well, such as NSAIDs, and he also denied any use of traditional medicine.
Oh, interesting. Okay. All right. So here, it's just getting a little tougher now because I've got no background history of anything that could help me out with the cardiac and renal pathology. However, it's not extremely rare to have a patient having a primary glomerular disease with no prior conditions before leading up to it. So it can be just a primary GN or nephrotic syndrome due to that. The gastritis part now gives me a clearer idea that the patient would have been suffering from an existing peptic ulcer disease all this while. And now it has ulcerated and it has caused bleeding. And that would explain the melena. Still can't see if it's linked to one another, but however, having said that, I will still address that together. And if the patient is in the ward right now, looking at the priority of the conditions, then I will have to initiate immediate resuscitation if that's necessary at this point of time, in terms of providing oxygen and also fluid resuscitation as the patient has been bleeding all this while. Without any history of traditional meds, no steroids, no over-the-counter medications, then I'm not thinking in the line of any steroid-induced problems, because steroids can also lead to fragile capillaries and they can bleed easily as well. Yeah, so I'm still standing on the fence at the moment, but I would still not exclude any cardiac or renal pathology at this point of time, even liver pathologies. I would like to know a little bit more about his social history to see if there's any intake of alcohol, because that's a commonly related problem to low albumin levels and liver disease in this country. And if there's any other autoimmune problems or any other diseases that run in the family, I would like to consider that, because he's young. I wouldn't want to miss out anything that has been running in the family and could be inherited.
Okay, so for the patient's familial history, there's no positive family history of any chronic medical illnesses or history of any hereditary diseases in this patient.
All right. And how about the social history part? What does he do?
Okay. So this patient, he currently works as a security guard. He's been married for the past 6 years. He works in a dengue-prone area where he claims that there has been frequent fogging. However, there's been no recent sick contact or any positive travel history in this patient. Adding on, the patient has been an active smoker, about 3 packs per day for the past approximately 10 years. And upon further questioning, the patient stated that he used to be a heavy alcohol consumer. However, the last time he consumed alcohol was about 10 years ago. He was unable to quantify the amount of alcohol he used to consume, but he mentioned that he's already stopped. And also the patient has history of methamphetamine use in 2002. He mentioned that this drug was inhaled. However, it was a one-time thing that he stopped in 2002. And the patient also has multiple tattoos over his bilateral forearm and lower limbs. When asked further about the history of his tattoos, he claimed it was also done about 10 years ago, here and there. He mentioned that it was done at home and he did not acquire proper equipment. He claimed that it was done together with his friends and there was no necessary sanitary measures that were taken at that time. And adding on to his social history a little bit more, he denies any recent history of using injectable drugs or any needle sharing. So yeah.
All right, so I think the social history gave out a little bit of clues there. The first part that was mentioned, which is he comes from a dengue prone area. Frequent fogging has been done. So of course, now putting it with the presenting illness where he had a preceding history of fever, nasal congestion, that is quite typical of presentation of dengue infection, where they come in with acute febrile illness. And the scary part about dengue is where it can progress into a state of severe dengue, where you can see patients having capillary leakage or plasma leakage, or in fact, even bleeding, hemorrhagic dengue. And these are among the areas that we get very afraid of when we see the word dengue. So assuming everything was happening very acutely, like in a day, yes, this definitely will now move up my list. And I would like to find out more because it took him a while before he came to the hospital. So from day 1 of fever, the time he came to the hospital was already day 6, day 7, I presume. So 1 week ago, right? It is within the time frame of the expected deterioration, where they go into the defervescence critical phase. And what's interesting is that usually patients come in much earlier. They would come into the hospital or they would have sought treatment from a clinic when they had those really high temperature spikes, and they feel really pathetic, body aches and feeling very unwell. This is the time they usually come in to get their medical leave and get some hydration going. So it's a little peculiar that he didn't show up in the initial period of the illness, and he came in when he developed acute breathlessness. So that would be still a consideration I have, which is severe dengue. So at this point of time, I'll be, cutting down the history taking, and I'll be rushing through the labs and also the vital signs and parameters to see if everything is going fine and if he needs acute resuscitation at this point of time. Also, you mentioned that he had multiple tattoos 10 years ago. Without any proper sanitary measures. Again, I'm not going to just jump on this right away and try to link that up because this was done more than 10 years ago. So if ever I want to tie something up previously to the current presentation, I will be thinking about something that has started earlier and progressing over time rather than something that happened a decade ago and now it's showing up. But yeah, I mean, for someone who had tattoos done before, there's definitely a consideration of could there be a possible viral hepatitis infection that he could be in a chronic carrier state that we don't know about, and that will be something that I would like to check later in the labs, and as I examine him as well. Apart from that, I don't see the history of the other health-related behaviors to be something directly related to his presenting complaint. For instance, 3 packs a year, 3 pack years, I believe, for smoking. Yeah, 3 pack years of cigarettes. Yeah, so having someone who's been smoking for 10 years now definitely want to consider COPD. Also don't want to miss out a lung malignancy. But, all that coming in a day still doesn't support the presenting complaint. These are other opportunistic screening that I would do when I'm examining the patient, but wouldn't be something that I'm considering at the top of my list. So yeah, after the social history part, now I'm beginning to consider a possibility of plasma leakage and giving rise to the acute decompensation at this point of time, where he comes in with anasaka and breathlessness.
Oh, I'm enjoying so much the way you're dissecting every single piece of information. And so far, just a quick question. You mentioned you would love to do some screening. Do you have any, like, a list of the main things we should screen for infectious disease wise?
Yeah, so this is a vector-borne condition, if I'm thinking dengue. Yeah, so very quickly at the initial history taking stage itself, we could quickly run a dengue test, which is an NS1 antigen test. It comes in a rapid test kit, also combined with the antigen antibody test. And that would give us a clue if this is dengue or not. And at this point of time, you might not expect to see NS1 to be positive, because that will be positive in the very initial period of the disease, which is within day 0 to day 3. And your antigen antibodies will start mounting its reaction, and that's what you will pick up later part of the disease. Now, that will definitely conclude that most likely the patient has dengue, and I'm going to manage the patient as dengue. Everything else comes as a subsidiary problem from this, because having dengue is a treatable problem. Okay, it's something that can be managed, and it's definitely something that we don't want to lose the patient to. So because it can progress to a very serious disease or condition in the end. That will be how I will look at dengue. Now, talking about other infectious screenings that we can do, we could run a screen for hepatitis B, your surface antigen antibody, and even your core antibody to see if the patient was infected. Hepatitis C antibodies, hepatitis A, a bit unlikely here. Also, given the fact that I'm not getting any history of jaundice or the patient having any form of liver disease signs at symptoms at this point of time. So nevertheless, given the fact that the patient had risk factors, that would be something that I screen right away together. And usually what we do is we also screen for HIV at the same time, because that's also a blood-borne disease that can be transmitted in the same manner. These will be the top 3 infectious screenings that we carry out. And if we carry on with the history and we find out if the patient has involved himself in any high-risk behaviors apart from injectable drugs, any other illicit sex or so on, or unprotected sex with multiple partners, then we also definitely want to screen for other sexually transmitted infections like chlamydia, gonorrhea, and syphilis, and so on. So yeah, so that would answer the screening for infections.
Thank you so much. This is a great approach on viral screening. And now we can jump into the physical exam and vitals.
Okay, so let's start with the patient's vitals. So his temperature was 36.4 degrees Celsius, which was about 97.5 degrees Fahrenheit. His heart rate was 88 beats per minute. Blood pressure 112/56 millimeter mercury. Respiratory rate 18 breaths per minute, and his SpO2 was 99% under room air. So I'll move on to his general examination. So the patient looked well and was appropriately built for his stature. There was no obvious jaundice or muscle wasting noted. However, on examination of his conjunctiva, there was pallor noted and mild scleral icterus. His cardiovascular, pulmonary, and neurological examination were all unremarkable. As for his abdominal examination, his abdomen was distended, soft, non-tender, and there was a positive fluid trill. His per-rectal examination revealed brownish stools with no fresh bleeding or no mucus, so there was no abnormalities noted. And as for his extremities, there was pedal edema noted up to his mid-shin. Yes.
What
And that's
about the respiratory component, Ash? Sorry, I missed that part.
It was unremarkable.
So there were breath sounds heard bilaterally equal.
Correct. No added breath sounds.
Okay, so so now the exam is giving me a little bit more information. So from here, I understand that typically I don't see anything that's wrong with the cardiovascular and the pulmonary component that would account for the dyspnea. So why is the patient having dyspnea? Another thing that we could consider here is the grossly distended abdomen. So with very gross ascites, one can expect the patient to have difficulty in ventilation because it's stretching, it's pushing the diaphragm, it's stretching it, and we're worried of diaphragmatic splinting at this point of time. Positive fluid thrill tells us that there's a large amount of fluid within the peritoneal cavity, and brownish stool, so the patient is not acutely bleeding at this point of time. And conjunctival pallor, interesting, with mild scleral icterus. So now we see probably there's some form of, possibility of hemolysis is what I'm considering as well. I mean, it's getting really complex, but always seeing pallor, pale, a pale patient with jaundice concomitantly, I definitely want to consider hemolysis. Could that be a possibility? Or else it could just be something that's unrelated where the patient is actively bleeding and also happens to have an underlying liver disease, chronic liver disease that's giving rise to perhaps the mild scleral icterus or jaundice. Let's just dissect a little bit of the vital signs. So under room air, the patient is having an appropriate saturation level, which is 99%. The respiratory rate happens to be within the expected normal range. So that's interesting because given the scenario here, I would expect the patient to be heavily tachypnic or at least having some form of respiratory distress. The heart rate is 88 beats per minute. So not really worried about decompensation at this point of time, but the blood pressure seems to be a little bit on the borderline low. Not too sure the size, how the patient's habitus or the size is. So is it appropriate to the patient's body? And instead of just looking at one snapshot of the vital signs, I'd be more interested to look at the trend or a serial reading of the vital parameters over maybe a couple of hours, half an hour, 1 hour. I would like to see if there is narrowing of the pulse pressure. That's something that I'm worried of in a person with dengue, severe dengue, and having plasma leakage. And whether is there decompensation in that sense. At this point of time, the patient's temperature is 36.4. So he's well defervesced at this moment. And were there any other signs that could tell us that, this is approaching severe dengue? Were there any signs that we missed out in terms of the warning signs or so, apart from abdominal pain, breathlessness? I don't see any. And given the fact that the pulmonary component is quite clear, now that's not something quite typical we would see in patients who are leaking in dengue. They would have pleural effusion together with gross ascites. So here we are just seeing ascites with upper and lower limb swelling. I'm probably going to now consider venous thrombosis at a point somewhere, but I'm not too sure where the obstruction would be here because it's also involving the upper limbs. At this stage, yes, definitely want to scan the abdomen and see what's going on. Maybe perhaps get an ECG as well, just to be sure that my physical findings are corroborating with the electrical rhythms that I'm seeing on the ECG, and there's no left ventricular hypertrophy, there's no previous remodeling, I'm not dealing with a cardiac problem. yeah, that will be where I'll be at this point of time.
Oh,
Any new input? Yeah.
Oh, definitely, definitely amazing information. Thank you. And just before we jump into labs, you mentioned that you would have curiosity in watching the trending on the vitals being uptrending or downtrending. Would you apply the same thought to labs, meaning, for example, the uptrending of red blood cells or uptrending of leukocytes, maybe? Would that affect also your diagnosis?
Yes, certainly. So an initial review of the labs will give me an idea if I'm dealing with dengue predominantly, where you will have lymphopenia, your platelets. At this point of time, if the patient is within the critical phase, I'm expecting the platelets to be low, the hematocrits to be climbing up. And if the patient is bleeding, then that's a big danger sign, because in patients who are leaking in dengue, you would expect their hematocrit and hemoglobin to be going up. But having a combination of leaking and bleeding at the same time, that's a very big danger here. So, which means that the patient has bled so much, and that has given the picture of anemia in a patient with dengue. So I'm skewing now very much towards dengue, and I've forgotten about all the other differentials that I spoke about earlier after going through the physical exams. So I don't know, at this point of time, something very acute as such with a prodrome viral illness, yes, still considering dengue. And the other thing I mentioned earlier on was anaphylaxis. But here with the examination findings, there's no wheezing, there's no rhonchi, except the fact that the patient is just edematous.
Definitely. Then maybe we can jump into the labs, Ashvin.
Okay, so let's move on. So the investigation-wise, it was started off with a full blood count, and it revealed bicytopenia with low hemoglobin of 7.7 grams per deciliter and low platelet of 56. The white cell count was within normal range. It was 4.93, and the hematocrit was indeed low. It was 29%. His coagulation panel revealed a prolonged prothrombin time of 18.6, and his INR and APTT, they were all normal. His urea and electrolytes were all within normal ranges. However, his liver test was deranged. His AST was 188, so it was elevated. His ALT was 98, also elevated, and his ALP was 240, which was also elevated. So as this patient works in a dengue-prone area, and as you mentioned previously, Dr. Lavanya, that you would want to do a dengue combo kit, so it was indeed done, but it yielded negative results. At the same time, although the patient appeared well and there was no obvious septic signs, we wanted to rule out any chances of septicemia. So a procalcitonin level was measured, and it was 0.11 nanograms per milliliter. So it was elevated, and a blood culture and sensitivity was done, but there was no growth found. So after the low hemoglobin levels and the deranged liver test was noted, the next step was to measure the LDH levels. So the patient's LDH levels, it was also elevated. It was 315 units per liter. Yes. Would you like me to continue with the imaging, or would you want to discuss?
Do you have the bilirubin, albumin, and the renal function test as well?
I do. So the bilirubin, the albumin, they were all within normal ranges. And the renal function test was also within normal ranges.
Interesting. How about a blood gas? Do you happen to have a blood gas with you?
Yes, I do have a blood gas, but it was also all normal.
Interesting. So the only abnormalities that we are seeing here is bicytopenia, which is anemia and thrombocytopenia, with a slightly high PT levels. And the other tests are essentially normal, except the liver function test, AST, ALT, and high LDH with a high alkaline phosphatase. So having dengue combo kit negative still doesn't exclude dengue, because that's a rapid test. We would still send off serology test to the lab to see if that's positive. But as you mentioned, the procalcitonin was raised without a remarkable raise in the white cell count. Here, I don't know if I'm considering something viral with superimposed bacterial infection that could have taken place, which is actually something not uncommon among dengue patients. Negative blood cultures here tells me that patient is most likely not bacteremic. So there is an element of blood loss that I'm seeing here, and the bilirubin levels are normal. This again doesn't really meet the scleral icterus, because I think there's a cutoff level for bilirubin levels in order for you to see it manifesting on the patient. Another thing that I could actually possibly consider would be not forgetting if the patient would have a renal involvement, lupus. Yeah, but do you happen to have the urine analysis here by any chance?
Unfortunately, I do not.
No. Okay, that's fine. But again, having said that, it doesn't really jive with the history, because the patient would have had a subacute presentation before, feeling unwell, fatigue, joint pain, or some other signs to give us a clue on that. Well, at this point of time, I'm still looking at a severe dengue infection with bleeding, with probably bleeding, yeah, and plasma leakage.
We have a little question. Like,
Yeah.
even if the dengue kit will be negative, would you consider doing a PCR on this patient?
The dengue kit is negative. Yes, definitely. If I'm still thinking about dengue fever, PCR will be a very good test to do. Also, I would send a serology test to the lab at the same time, but that would take some time to come back. Yes, I would definitely try to confirm if this is dengue or not. And dengue come in various strains, so depending on which particular test that we are looking at.
Thank you so much. Well, Ashwin, do you have more information about this patient?
Yes. So we'll move on to the imaging. So the EKG showed normal sinus rhythm with no ischemic changes. And a bedside fast scan was done. And they noted there was minimal pleural effusion in the right lower zone of the lungs. There was fluid in the perihepatic, splenorenal, and rectovesical regions as well. I could also give you an abdominal ultrasound, or would you like me to tell you later? Would that be helpful?
So from the bedside scan, I understand there's a plasma leakage, certainly, and there's fluid collection in the areas where I'm expecting to see fluid collection in a patient with leaking dengue. Was there anything different on your abdominal scan? Was there anything extra?
Okay, so on the ultrasound abdomen, it revealed that the liver was 11 centimeters, so it was of normal echogenicity with coarse texture. It had slightly irregular margins, but no focal lesions. The spleen was enlarged. It was 16.5 centimeters, but there was no focal lesions. Everything else, the gallbladder, the pancreas, the kidney, the urinary bladder, the prostates, they were all normal. And there was no free fluid except for the right pleural effusion noted.
So there's splenomegaly now, which was not very apparent, or probably because of ascites on examination. So, but was the trop space dull on the examination looking back? Probably. Yeah, so at this point, again, with the new information that the spleen is enlarged, I'm thinking, could there be portal hypertension that would have led to, ascites with splenomegaly, and finding out what is the underlying cause. That would be more of a subacute to chronic problem rather than something acute. They could be two separate pathologies altogether. But at this point of time, I would suggest to get a peritoneal tapping done since there's gross ascites. All right. And since the pleural effusion is very minimal, I wouldn't proceed and do a tapping there for the chest. Still sending a dengue test, PCR and serology to confirm. Transfusion if it's indicated if the patient is symptomatic in that sense. But yeah, essentially my workup will be to look for where the source of bleeding is, and endoscopy for sure, to see if there's any upper GI bleed that's going on. If the patient has got any other bleeding disorders. Yeah, that would be my chain of thought at this point of time. Yeah.
Do you have any more information, Ashby?
I actually do. So as you were suggesting, a dengue serology was sent, but it did come up negative. Besides that, the doctors also sent hepatitis and HIV serology. So the HIV and hepatitis B serology was negative, but the hepatitis C serology was positive.
Okay. So we are quite sure that the patient has got viral hepatitis and could be in a state of chronic disease at this point of time with cirrhosis probably. But given the acute presentation of dyspnea and upper and lower limb swelling, I would want to, try to see if there's any trigger factor to it that brought the patient in for that. Yeah. So I think I'm pretty exhausted at this point of time in terms of finding out the exact diagnosis. I would manage it as I'm going in terms of the stages. So targeting, if I would need to work on the intravascular component, if the patient is intravascularly deplete because of third space fluid loss, if the patient is having any active bleeding at this point of time, correcting the coagulopathies. And if I'm certain now that dengue is negative, then I not need to worry about that much at this point of time. A definite paracentesis tab, just to exclude if there's spontaneous bacterial peritonitis as well. So the management of chronic liver disease in a patient with viral hepatitis, and if it's sure, then I'm going to ring up my hepatologist to see if I can initiate treatment for the patient once he's a little stable. So
that's an amazing diagnosis. Just a quick question. Do you think that this chronic condition could have been triggered by, for example, the flu illness that this patient have, or do you think there could have been another trigger?
The flu illness triggering a hepatitis C flare as such, I've not seen that one before, but bleeding itself can put the patient at a state of decompensation. Or if the patient had any other triggers such as maybe constipation, infection wise, it's not abnormal to have infection triggering any other indolent diseases that's quiet inside. But I didn't actually expect the low grade fever to tip a person off into a very acute state like so. Yeah,
definitely.
This is interesting.
Really interesting to see hepatitis C presenting this way.
Yeah.
Thank you for this amazing case. We hope to have you with us again. Janessa Ashbin, thank you for presenting this great case, and Dr. Lavanya for dissecting every single piece of information in such a way. Now, I think we can jump with Ibrahim, that is going to do teaching points today.
Okay, so thank you, Dr. Ashbin and Dr. Fernandez for bringing on this case. And thank you, Dr. Lavanya, for taking the time to dissect this amazing case. So this case started with the limb swelling and breathlessness. And our first question was the progression of such a swelling and breathlessness. as it would clue us further into the diagnosis. And then we also started thinking about whether or not these were related or isolated processes. If there were related processes that occurred concurrently, such as in our case, we would think about acute, dynamic, and systemic causes, including pulmonary edema as well as pleural effusion. Now, another interesting point as well that you should go into if a patient presents to your clinic with limb swelling and breathlessness is the prior history, the prior family history, as well as the prior social history. The prior history itself would clue us into whether this is a new problem or something that had been recurring for a long period of time. And then there are also specific points within the prior history that you can look into. So for example, for such a patient who had prior fever before presenting, he should probably think about influenza and dengue. You should think about dengue if they're presenting from an endemic region, especially considering the fact that severe dengue may be characterized by hemorrhage. But those patients would usually present earlier because of the severity of their illness. If you would like to rule out or rule in dengue, you should probably do rapid kits as well as serology. The rapid kits are only positive within the first 3 days. If the patient has a later presentation, such as in our case, you should send for serology. And then you should also look into the bleed. So this patient had a prior history of bleed. Specific points that you could ask the patient include variceal bleeding, as well as the use of NSAID. So NSAIDs could clue you as a physician into peptic ulcer disease, as well as renal history. So renal history is important for such a patient who is presenting with anasarca. For the family history, you want to look into genetic causes. So you should probably ask if there is a family history of such a similar presentation. And then finally, for the social history, such a patient had the social history of tattoos. And when a patient has tattoos, you should probably start thinking about decompensation of viral hepatitis causing their presentation. And because of that, you should probably order a hepatitis panel. And with the hepatitis panel, you should also order for an HIV antibody. And then for the past history as well, the past social history, this patient was a smoker. However, they were presenting acutely. If they were presenting chronically, you should probably think about COPD due to their just presentation, due to their shortness of breath, as well as malignancy. Now for the edema that this patient had presented with acutely, you should also look for allergy and anaphylaxis first. So, and then in allergy and anaphylaxis, you could probably rule them out if you look further into the respiratory tract symptoms. So this patient did not have any respiratory tract symptoms. So we safely ruled out anaphylaxis and allergy. But another point that you could look into as well is skin involvement. And then for the anasarca that this patient was presenting with, you should probably look into cardiac versus renal versus hepatic versus thrombotic causes. Those are related to low oncotic pressure, increased hydrostatic pressure, as well as increased capillary leakage. In cardiac causes, you could look into cardiac specific causes. Renal, you should look into primary glomerulonephritis or SLE if the history would point out to such a diagnosis. And then for hepatic, we looked into it specifically because this patient had a history of alcohol consumption, as well as thrombosis as well. For the bleed, initial presentation of a patient with the bleeding, you should probably think about fluid resuscitation. And then onto the physical examination, there are different points that you could look into. You could look into the vitals, and you should look into the trend of the patient. So if they had lowering of pulse pressure, that could clue you further into dengue. The hemoglobin trend as well. If it was decreasing, you should probably think about bleeding, which would occur in dengue as well. For the jaundice on physical examination, again, this would make you think further of hepatic versus hemolysis. And then in such a specific presentation of our patient, you should probably consider peritoneal tap if on physical examination the patient had ascites. And then also, since this patient seems to have multiple manifestations upon presentation, you could also think about subacute on top of a chronic process that had been occurring. And you should consider endoscopy for upper GI bleeds, as well as sending off hematology workup for any coagulopathy. And then this patient ended up having positive HCV. For such a patient, how you would actually initially manage them is that you should correct for the coagulopathy that they might have. You should resuscitate them if they need that. And then eventually to understand why they have this decompensation of their hepatitis C, you should consider doing a peritoneal tap. I think that's all. Thank you all for the case.
Thank you so much, Ibrahim. This is an amazing recap of this great teachings from Dr. Lavanya. We have unfortunately arrived to the end of our session. So Dr. Lavanya, we hope to have you here again soon, and have a great day, everyone. See you.
Thank you very much, guys, and thank you, Ibrahim. You did such a wonderful job. Thank you, Yasmin. You're amazing. Thank you, guys. Thanks for having us.
Thank you, everyone.
See you next time.
See you.